If you break your arm, the X-ray shows that jagged white line, and the doctor just points and says, "There it is."
Yeah, I mean, it's the ultimate comfort in medicine, right? We really crave those binary answers. Broken or not broken, healthy or sick.
Right, exactly. We want to see the problem clearly mapped out on a backlit screen.
But then you step into the world of human development, specifically the earliest stages of human biology, and suddenly that X-ray machine is completely useless.
Yeah, the diagnostic landscape there doesn't give you a clean white line. It gives you this incredibly complex, overlapping web of signals.
Which becomes incredibly apparent the moment you look at the clinical presentation we're jumping into today. It's by Dr. Inyabong Okan Udo.
Right, from the Department of Pediatrics and Child Health at the University of Uyo Teaching Hospital.
Exactly. And the focus of this deep dive is to really unpack the clinical approach to disorders of sexual differentiation, or DSD.
And I want to paint a picture for you, the listener, of why this specific area of medicine is just so intense. Just picture a delivery room.
Okay, yeah.
A baby takes its first breath. The parents are exhausted. The grandparents are waiting by the phone. And the very first question anyone asks, before they even ask about the baby's health or their APGR score, is always the same. Is it a boy or a girl?
It's the defining social checkpoint, you know? It's a human being's entry into the world.
Right. And in the vast majority of births, the medical staff takes a quick glance at the external anatomy and provides an immediate answer.
But DSD refers to a spectrum of congenital anomalies where that quick glance simply isn't enough. It's a situation where a person's genetic sex, their internal gonads, and their external physical appearance, well, they just do not align.
And Dr. Udo's presentation explicitly calls this a social emergency, which is a phrase that really stuck with me.
It's powerful.
It really is. It's not just a medical puzzle, right? It is a profound societal pressure test. The medical team is suddenly caught between the parents' desperate desire for a simple binary answer and a deeply nuanced biological reality.
And managing that tension requires an incredibly delicate, highly coordinated balance. I mean, you are dealing with emergency medicine, advanced genetic sequencing, endocrinology, and profound psychological support all at once.
All while the family is experiencing what should be the happiest moment of their lives.
Exactly. And to understand the scale of this, we really need to look at the numbers. Because this is not some incredibly rare, isolated anomaly that only exists in medical textbooks.
Like, this is a universal human reality.
Yeah, the global epidemiological data is quite revealing. Worldwide, it's estimated that anywhere from 0.05% to 1.7% of babies are born with some form of a DSD.
Wow, okay.
If you look at the U.S., that averages out to about 1 in 2,000 births. But the regional data, particularly the Nigerian studies cited in Dr. Udo's work, show these immense and fascinating fluctuations.
Yeah, I noticed those variations in the source. The numbers jump around significantly depending on the specific region being studied, right?
They really do. Like a study by Oluwayemi reported a prevalence rate of 3.51% in Ado Ekiti over an 8-year period. Akinola reported 1.7% in Lagos.
Okay.
Then you have Itafo and Briggs reporting 3.4% in Port Harcourt. Jarrett found 10.6% in Ibadan. And Onyeriyuka reported a staggering 13.8% in Benin.
Wait, 13.8%. How do we account for a jump from 1.7% in Lagos to almost 14% in Benin? Is that a genetic difference or is something else happening there?
Well, it's likely a combination of several factors. Different regions definitely have different genetic pools, and environmental factors play a part.
Like what?
Well, consanguinity, for instance, parents who are closely related, that can play a big role in autosomal recessive conditions. However, the most significant factor is often just how these conditions are screened, defined, and reported in local hospitals.
Oh, I see. So it's about the data collection itself.
Exactly. A hospital that rigorously screens for even the mildest forms of hypospadias, where the urethral opening is just slightly displaced, will report a massively higher prevalence than a hospital that only logs cases of completely ambiguous genitalia.
That makes total sense. But the ultimate takeaway from those numbers is that DSD is a significant, ever-present aspect of human biology. Clinicians absolutely must be prepared to navigate it.
They must. And to understand how a clinician navigates a divergent path, we first have to understand the standard blueprint.
Right. So I want to go all the way back to the embryological foundation. What is actually happening in the first few weeks of a pregnancy?
Okay, so early in the first trimester, we are looking at an embryo that is entirely undifferentiated. Every single human being starts with what is called a bipotential fetal gonad.
By potential, meaning it has the raw capacity to develop into either male or female structures, right? Like it hasn't chosen a lane yet.
That is the perfect way to phrase it. Physically, it begins as a slight thickening of tissue called the urogenital ridge, which is formed from intermediate mesoderm.
Okay, mesoderm, got it.
If you were to look at a genetically male embryo and a genetically female embryo under a microscope at this early stage, up until about the 6th week of gestation, there is absolutely no anatomical difference.
They're physically identical.
Completely identical.
So week 6 is the pivot point. What exactly triggers the change then?
Well, by the 6th week, this bipotential gonad contains raw germ cells. Depending on the genetic instructions they receive, these germ cells will eventually become either the Leydig cells of the testes or the Aca cells of the ovaries.
Okay.
The gonad also contains supporting cells, which are destined to become either Sertoli cells in males or granulosa cells in females. And the fate of all these cells hinges on the presence or absence of the Y chromosome.
Or more specifically, it hinges on a tiny fragment of that chromosome, right?
Yes, a specific region on the short arm of the Y chromosome, called the SRY gene, the sex-determining region Y. When the SRY gene is present, it acts as a massive biological switch.
You know, I think of the SRY gene as kind of like a biological project manager.
Yeah.
Like we all start with the exact same architectural blueprint.
Right.
But at week 6, the project manager steps onto the construction site, pulls out a megaphone, and says, okay, everyone, we are pivoting to build a male structure.
I really like that analogy. The project manager actively stimulates the differentiation of those supporting cells into Sertoli cells. Once those Sertoli cells form, they immediately start producing a hormone called AMH.
Anti-Müllerian hormone.
Exactly. Simultaneously, the Leydig cells develop and begin churning out testosterone. But the SRY gene doesn't build the entire structure alone. It relies on a whole complex choir of other genes to actually execute the blueprints.
Yeah, the outline mentions a whole alphabet soup of these supporting genes, like SOX9, SF1, WT1, FGF9, G84, XH2.
Yeah, and each one has a highly specific job. SOX9, for instance, is a critical transcription factor that works directly downstream of SRY.
So if SRY is the project manager, SOX9 is the lead foreman actually building the testicular tubules.
Precisely. Gonal differentiation is this multi-step, incredibly intricate cascade.
What happens if the project manager never shows up to the site?
If SRY is absent, which is the typical path for an XX chromosome pairing, the biological default pathway continues. The bipotential gonad develops into ovaries instead of testes.
Okay.
And the Müllerian ducts, which would have been destroyed by the anti-Müllerian hormone in a male, are allowed to mature into the uterus, the fallopian tubes, and the upper part of the vagina.
But the project manager can also get lost, right? Or mutate, or show up on the wrong job site entirely.
Yes, unfortunately. During the process of cell division, specifically meiosis, when sperm and eggs are formed, chromosomes can sometimes cross over and swap pieces of DNA.
Wow. Yeah.
You can have an abnormal recombination where the X chromosome accidentally picks up the SRY gene. This results in an XX male.
Wait, really? An XX
Yep.
male?
Genetically, they have 2 X chromosomes, but because that project manager gene sneaked in, they develop tests. Conversely, you can have an XY female, where the Y chromosome accidentally lost the SRY gene during division.
Which brings us to the actual clinical environment. Because a baby is born, the external genitalia are ambiguous, and the medical team is called in.
Right.
Because DSDs can be caused by these genetic misfires or by hormonal disruptions in the womb, the very first tool a clinician uses isn't a scalpel or a blood test, is it? It's an interview.
Yes. History taking is the critical first line of inquiry. The clinician has to look backward in time, basically becoming a detective investigating the 9 months of gestation and even the generational history of the family.
So where do they start?
They begin by asking the mother about pregnancy drugs.
Are there specific medications that can actually cross the placenta and alter fetal development like that?
Absolutely. The clinician will ask if the mother used any exogenous androgens, progestins, or certain anticonvulsants. Historically, like in the mid-20th century, synthetic progestins were sometimes given to women to prevent miscarriages.
Oh, wow.
Yeah, and medical science later discovered that these synthetic hormones could cross the placenta and exert a masculinizing effect on a genetically female fetus.
That's terrifying. But the clinician also has to ask about maternal illness, right? Did the mother experience virilization during the pregnancy?
Exactly. They're looking for signs that the mother had an excess of circulating male hormones or androgens in her own system. Did she develop excessive facial hair, acne, or a deepening voice during those 9 months?
And what would cause that?
It could be caused by a maternal condition like an androgen-secreting tumor, such as a luteoma of pregnancy. They'll also inquire about her general endocrine health.
Like diabetes and things like that?
Yeah. Does she have poorly controlled diabetes, thyroid disease, polycystic ovary syndrome, or her own underlying case of congenital adrenal hyperplasia? Any of these can drastically alter the delicate hormonal environment of the womb.
Then there is the broader family history. The clinician has to ask questions that might seem incredibly intrusive or just painful in the moment, like recurrent miscarriages, stillbirths, or if any previous babies were born with ambiguous genitalia.
Yeah. The most crucial and often the most tragic question a clinician must ask is whether there's a family history of early neonatal death.
Early neonatal death.
Have they ever had a baby, or has anyone in their extended family had a baby who suddenly died within the first few weeks of life from an unexplained illness?
I'm trying to connect the dots here. Why would an unexplained infant death in a sibling be a clue for a disorder of sexual differentiation?
Because it strongly hints at an undiagnosed fatal adrenal crisis. As we'll explore in depth later, the most common cause of ambiguous genitalia in genetically female infants is congenital adrenal hyperplasia, or CAH.
Okay.
Severe forms of CAH completely destroy the body's ability to retain salt and regulate blood pressure. If a baby with severe CAH is born and the condition isn't caught, they will go into hypovolemic shock and die within days.
Oh, that's heartbreaking. So if a family has a history of losing babies in the first few weeks of life, the clinician's internal alarm bell should be ringing at maximum volume. They're likely looking at a genetic adrenal failure.
Exactly. The history also covers other potential disruptions. Fertility treatments like IVF or clomiphene for ovulation induction.
Right.
Exposure to environmental toxins, severe maternal infections, or a history of intrauterine growth restriction, where the baby simply wasn't growing properly in the womb due to placental issues.
So every single answer helps the clinician build a working hypothesis. They're gathering the contextual clues before they even lay hands on the patient.
That's right.
And once that history is gathered, they transition to the physical examination. They start mapping those potential genetic and hormonal misfires onto the patient's actual anatomy.
And the presentation makes a point that the clinician doesn't just walk in and immediately look at the pelvis. They start with a macro view. They are looking for systemic signs of distress.
They're evaluating whether this is an isolated anatomical variation or a symptom of a massive systemic storm.
Yes. The most urgent signs they look for are adrenal flags. Is the infant severely dehydrated? Is their blood pressure dangerously low? And crucially, do they show signs of hyperpigmentation?
Wait, let's pause on the hyperpigmentation. Severe dehydration and plummeting blood pressure make logical sense if a major organ system is failing. But how does a sex differentiation disorder change the actual pigment of the newborn's skin?
It is a fascinating biochemical domino effect. It all goes back to that adrenal failure in CAH. The adrenal glands sit on top of the kidneys and are supposed to produce cortisol, which is our primary stress hormone.
Oh.
In CAH, the factory is broken. Cortisol production plummets. The brain, specifically the pituitary gland, senses this dangerous drop and panics. It starts churning out massive amounts of a signaling hormone called ACTH, essentially screaming at the adrenal glands to work harder.
So the brain is just flooding the bloodstream with a chemical megaphone.
Yes. But ACTH doesn't just materialize out of nowhere. It's cleaved or cut from a much larger precursor protein molecule called POMC.
EOMC.
Right. When the brain ramps up production of POMC to make all this emergency ACTH, it inadvertently creates byproducts. And one of those byproducts is melanocyte-stimulating hormone, or MSH.
And MSH is what stimulates the melanocytes in the skin to produce melanin.
Exactly. The brain is desperately trying to save the child's life by printing more cortisol signals, but because those signals share a biochemical factory with skin pigment hormones, the infant's skin becomes noticeably darker.
Wow. Okay. Where does it show up most?
Particularly around the nipples, the genitals, and the creases of the skin. So hyperpigmentation in a newborn with ambiguous genitalia is an immediate flashing warning sign of an impending adrenal crisis.
That is wild. And the physical exam also involves looking for syndromic clues, right? unrelated physical anomalies that might indicate a broader genetic deletion or mutation.
Right. The clinician examines the face for dysmorphic features, unusual spacing of the eyes, low-set ears, or a flattened nasal bridge. They look for skeletal abnormalities too.
Dr. Uda's material highlights several specific syndromes where DSD is just one piece of a much larger puzzle. Denny-Drash syndrome is a primary example.
Yes.
What defines Denny-Drash?
It's caused by a mutation in the WT1 gene. Patients typically have a 46XY karyotype, so genetically male, but present with ambiguous genitalia. But the DSD is secondary to the real threat here.
Which is?
WT1 mutations cause early-onset nephrotic syndrome. The filtering units in the kidneys rapidly fail. Furthermore, these patients have an extraordinarily high risk of developing a specific aggressive childhood kidney cancer called a Wilms tumor.
That is so severe. There's also Wagner syndrome, which is an acronym, right?
Yes. Wagner stands for Wilms tumor, aniridia, genitourinary malformations, and mental retardation, though the medical community now uses the term intellectual disability.
Right, of course.
Aniridia is a striking physical clue. It's the complete or partial absence of the colored part of the eye, the iris.
Oh, wow.
If a clinician sees an infant with ambiguous genitalia and missing irises, they immediately suspect Wagner syndrome, which is caused by a deletion on chromosome 11.
And the third syndrome mentioned is Camptomellic syndrome.
This brings us back to our embryology discussion. Camptomellic syndrome is a rare genetic disorder caused by a mutation in the SOX9 gene.
Right, the formin gene we talked about earlier.
Exactly. We know SOX9 works directly with the SRY gene to build the testes. If SOX9 is mutated, the testes don't form properly, resulting in DSD. But SOX9 is also heavily involved in the development of cartilage and bone.
Oh, I see.
Therefore, a mutation here causes severe skeletal abnormalities, bowing of the long bones in the legs, and a distinctive facial structure.
Okay, so once the clinician has completed this systemic survey, assessing the vital signs, the skin, the facial features, and the skeleton, they finally focus on the external genitalia.
Yes, they have to conduct a highly precise anatomical inventory. They are essentially mapping a spectrum.
What exactly are they looking at?
They evaluate the phallic size. Are they looking at a microphallus, an unusually small penis, or clitoromegaly, an unusually enlarged clitoris? Often it sits somewhere in the middle, defying easy categorization.
And they examine the urethral opening to see where the urine exits.
Right. Yes, they check for hypospadias. In a typical male, the urethra opens at the tip of the glans. In hypospadias, the opening is displaced somewhere along the underside of the penis, or even further down near the scrotum or the perineum.
And the severity of the displacement is a major indicator of how undermasculinized the tissue is.
Precisely. Then they have to locate the gonads.
Which seems tricky. If the external genitalia are completely ambiguous, how do they even know if they're looking at descended ovaries or undescended testes? Is there a physical way to feel the difference?
It requires careful palpation. The clinician will gently feel along the inguinal canal, which is the pathway the testes take as they descend from the abdomen into the scrotum during fetal development.
Okay.
Ovaries almost never descend into the inguinal canal or the labioscrotal folds. This for if a clinician feels firm oval mass in the groin or the folds of an infant who otherwise appears female, they can strongly suspect they are palpating a testes. Conversely, if they examine an apparent male infant and the scrotum is completely empty by lateral cryptorchidism, they know the internal development did not match the external appearance.
They also examine the degree of labioscrotal fusion, I believe.
Yes. In early fetal development, there are folds of tissue that either remain separate to become the female labia majora or fuse together in the midline to form the male scrotum. The clinician assesses exactly how far that fusion has progressed.
And they check the position of the anus as well, right?
Right.
Because anorectal malformations can sometimes occur alongside DSDs.
Exactly.
We are so accustomed to thinking of physical sex as a coin flip, heads or tails. But listening to this physical exam checklist, it sounds more like reading a topographical map where the train can settle anywhere along a vast sliding scale.
That's a great way to put it.
But the outside of the body is providing incomplete information. How does a clinician avoid personal bias when interpreting these physical signs?
Human observation is inherently subjective. A clinician might look at an enlarged phallus and call it a small penis, while another might call it an enlarged clitoris. To remove that bias, to find the biological truth, the clinician has to look under the hood.
Right. They must move to the clinical toolkit, the investigations. Clinicians cannot rely on visual guesswork when the stakes are this high.
Absolutely not. They need to see the internal chemistry and the genetic architecture. This requires laboratory workups, starting with what Dr. Udo calls the emergency baseline.
Which means before they worry about genetics or sex assignment, they must ensure the infant is not actively dying.
Exactly. The very first blood tests drawn are serum electrolytes and glucose.
They're looking for the biochemical footprint of that adrenal crisis we discussed.
Precisely. They are hunting for hyponatremia, which is dangerously low sodium in the blood. They look for hyperkalemia, dangerously high potassium, and hypoglycemia, severe low blood sugar.
Why does that happen?
When the adrenal glands fail to produce aldosterone, the kidneys lose the ability to retain sodium and excrete potassium. The sodium washes out in the urine, pulling massive amounts of water with it, leading to fatal dehydration and shock.
Oh, wow.
And the potassium builds up in the blood, which can trigger lethal cardiac arrhythmias.
Okay, so once they've pulled the emergency labs, they draw blood for a comprehensive hormonal panel. The list in the source includes 17-OHP, cortisol, ACTH, testosterone, DHT, LH, FSH, and AMH.
Quite the list.
I want to zero in on 17-OHP. Why is that specific marker so crucial?
17-OHP or 17-hydroxyprogesterone is the primary diagnostic marker for congenital adrenal hyperplasia.
Okay, explain how that works.
Let's imagine the adrenal gland as a chemical assembly line. Cholesterol comes in at the start, and it goes through a series of workers' enzymes who change it step by step until it becomes cortisol.
Right.
17-OHP is the molecule sitting on the conveyor belt right before the most critical step.
And in CAH, the worker at that critical step is missing.
Yes. The enzyme, 21-hydroxylase, is absent. So the conveyor belt keeps bringing 17-OHP to that station, but no one is there to process it.
So it just piles up.
Exactly. The 17-OHP just piles up and up and up. By measuring the massive accumulation of 17-OHP in the blood, the clinician can definitively prove that the cortisol assembly line is broken.
That is such a clear analogy.
Yeah.
And they also perform genetic testing, usually pulling a karyotype or doing rapid SRY testing.
Right. A karyotype involves taking a sample of the infant cells, usually from the blood, culturing them, and arresting them during cell division. The laboratory then literally stains and photographs the chromosomes to look at them under a microscope.
What exactly are they looking for?
They are counting to see if there are 46 chromosomes, and they're looking to see if the sex chromosomes are XX, XY, or something else entirely. Rapid PCR testing can also be used to quickly detect the presence of that crucial SRY gene.
Now, Dr. Uda emphasizes a golden rule regarding these blood draws. He says that whenever it is feasible, the medical team must collect these diagnostic samples before they administer any life-saving steroid treatments.
That's right. Because if you pump the infant full of synthetic cortisol before you draw the blood, you completely alter their hormonal baseline. You effectively erase the diagnostic evidence of the adrenal failure, making it incredibly difficult to confirm the diagnosis later.
I have to push back on the reality of that scenario, though. If a newborn is actively crashing from hypovolemic shock, their blood pressure is tanking and their heart is struggling. Trying to secure a massive panel of rare hormone tests before treating them feels like asking a mechanic to run a full diagnostic software check while the car's engine is actively engulfed in flames. How do doctors balance gathering evidence with immediate survival?
You are hitting on the fundamental tension of emergency pediatric medicine right there. The caveat to the golden rule is absolute. Survival always overrides the perfect diagnostic sample.
Okay, good.
A clinician must never delay life-saving treatment just to get a blood draw. If the baby is in shock, you treat the shock. You push IV fluids to restore the blood volume. You push dextrose for the blood sugar.
But try to get the blood if you can.
Yes, if you can grab a quick vial of blood while you are placing the IV line, wonderful. But you do not withhold the heavy therapeutics, the hydrocortisone, if the child is fading. It requires immense clinical composure.
So beyond the blood work, they use radiology and dynamic stimulation tests to visualize structures that are hidden from the naked eye.
Imaging is critical. They will typically start with a pelvic and abdominal ultrasound. Sound waves are used to peer into the pelvis to see if a uterus or the upper portion of a vagina is present.
And they also use the ultrasound to hunt for the internal gonads, right? Trying to locate tests that might be trapped high in the abdomen.
Exactly. And if the ultrasound doesn't provide a clear picture, they can escalate to an MRI or use genetograms.
What's a genetogram?
It involves injecting a radiopaque contrast dye into any perineal openings and taking an X-ray. It beautifully outlines the internal architecture of the vagina, the urethra, and any abnormal connections or fistulas between them.
That dynamic testing sounds fascinating. It isn't just taking a static snapshot of the blood. It's actively poking the biological system with a stick to see how it reacts.
That is exactly what it is.
Yeah.
For example, an HCG stimulation test. The clinician injects human chorionic gonadotropin, a hormone that mimics LH or luteinizing hormone.
Okay, and what does LH do?
In a typical system, LH wakes up the Leydig cells in the testes and tells them to produce testosterone. By injecting HCG and then measuring the blood days later, the clinician can see if there is a spike in testosterone.
Oh, I see. So if there is a spike, it proves that functional testicular tissue is present somewhere in the body, even if they can't physically find it on an ultrasound. We have to acknowledge the reality on the ground, though. Dr. Udo includes a crucial section on the peculiarity of our setting, specifically referring to medical practice in resource-constrained environments or developing nations like the setup at UUTHI.
It is a sobering reality check. Advanced pediatric MRI machines, rapid 24-hour genetic panels, and comprehensive hormone assays are incredibly expensive and simply not available in many hospitals globally.
Right. So clinicians in these settings cannot rely on a machine to give them the answer. They have to rely on raw clinical acumen and highly experienced hands.
That's right.
How do they adapt? I mean, if you can't order a fancy chromosomal blood test, how do you map the genetics?
They utilize older, more accessible techniques. Instead of a full blood karyotype, they might perform a buccal mucosal smear.
A buccal smear.
They gently scrape the inside of the infant's cheek with a swab, smear the cells on a glass slide, stain them, and look for bar bodies under a basic microscope.
What's a bar body?
The presence of a bar body indicates an inactivated X chromosome, which strongly suggests a female X genetic makeup.
Wow. Okay. And if advanced MRI isn't an option to find internal organs?
They rely heavily on the interpretative skill of senior ultrasonographers. If the ultrasound is still inconclusive, they may have to resort to surgical exploration.
Like actually opening them up?
Yeah, a surgeon will perform a laparoscopy, inserting a small camera into the abdomen, or even an open laparotomy, simply to visually confirm the presence of a uterus or internal gonads and take physical tissue biopsies.
It really underscores the incredible skill required to manage these cases when you don't have infinite technological resources.
It truly does.
So once all this evidence is gathered, the history, the systemic exam, the genital mapping, the blood chemistry, and the imaging, the medical team faces the daunting task of categorizing the findings. They have to render a diagnosis.
Right. But before we delve into the specific diagnostic categories, we must acknowledge a massive paradigm shift in the medical community's approach to this field.
Oh, you mean the terminology change?
Yes. In 2006, the Lawson-Wilkins Pediatric Endocrine Society, alongside the European Society for Pediatric Endocrinology, convened to publish a landmark consensus statement.
This was the moment they officially urged the medical world to abandon older terminology. Words like hermaphrodite, pseudo-hermaphrodite, and intersex were retired from clinical guidelines. Why was that linguistic shift so necessary?
It was driven by both clinical clarity and profound human empathy. The older terms were rooted in ancient mythology and were deeply confusing to both general practitioners and patients.
Right.
More importantly, patient advocacy groups clearly communicated that terms like hermaphrodite were perceived as highly pejorative, stigmatizing, and psychologically damaging.
Which makes perfect sense.
Yeah. So the consensus proposed the umbrella term disorders of sex development, or DSD, classified strictly objectively on the basis of karyotype analysis.
Let's walk through that modern classification system. The first major category is 46XX-DSD.
Okay. In a 46XX DSD, the infant has the standard genetic makeup of a female 2X chromosomes. They possess normal ovaries and a uterus. However, they exhibit overvirilization, meaning atypical masculinization of their external physical traits.
And as Dr. Udo notes, the overwhelming majority of these cases, over 90%, are caused by congenital adrenal hyperplasia.
Yes.
We discussed the missing 21-hydroxylase enzyme and the buildup of 17-OHP, but I want to trace the mechanism all the way through. If the cortisol assembly line is broken, how exactly does that lead to masculinization of female anatomy?
Well, when the cholesterol molecule hits that roadblock, the missing 21-hydroxylase enzyme, it can't become cortisol. But the brain is still pumping out ACTH, screaming at the factory to keep working, keep pulling in raw materials.
Right, the chemical megaphone.
The factory is overflowing with precursor molecules. Because the path to cortisol is blocked, all of those accumulated precursors spill over into the only biochemical pathway that is still open.
The androgen synthesis pathway.
Exactly. The adrenal gland starts acting like a runaway train, producing massive, excessive amounts of androgens, male sex hormones, like testosterone.
Wow.
Because this is happening in the womb during the critical window of fetal development, those excess androgens bathe the developing female external genitalia, causing them to virilize.
What does that virilization look like physically at birth?
It varies on a spectrum, often measured by the Prater scale. It can range from mild clitoromegaly, a slightly enlarged clitoris, to a completely fused labia that heavily resembles a male scrotum, complete with a phallus that encloses the urethra.
So to the naked eye, the infant might look entirely male, but internally they have ovaries and a uterus.
Precisely.
And if this 46XXCAH goes unmanaged into childhood, the androgen excess continues to wreak havoc, doesn't it?
Oh, absolutely. Without treatment to suppress that runaway factory, the child will experience severe precocious puberty. You will see rapid explosive somatic growth in early childhood. They will be significantly taller than their peers.
But doesn't it eventually stunt their growth?
Yes. Those same high levels of androgens will cause the growth plates in their bones to fuse and close prematurely. Their growth stops early, ultimately resulting in a stunted, short adult height.
That's a severe trade-off.
It is. They may develop excessive muscularity, severe acne, a deepening of the voice, and they will experience primary amenorrhea. They will never begin menstruating because the hormonal environment suppresses normal ovarian function.
That is the mechanism of overvirilization. The second category flips the script. 46XYDSD.
Here, the individual is genetically male. They have one X and one Y chromosome. But they experience undermasculinization, resulting in atypical development of their external genitalia, or sometimes completely female typical external genitalia.
And this occurs because of errors in either making the male hormones or in the body's ability to actually use them.
Yeah.
Let's look at the first error, 5-alpha reductase deficiency.
Right, we established earlier that the fetal testes produce testosterone, but testosterone alone isn't potent enough to fully construct the male external genitalia, the penis and the scrotum.
So it needs an upgrade.
Yes. The body utilizes an enzyme called 5-alpha reductase to convert testosterone into a supercharged hormone called dihydrotestosterone, or DHT. DHT is the heavy machinery that drives external masculinization.
So if a genetic mutation means you were born without the 5-alpha reductase enzyme, you can't make the heavy machinery.
Precisely. The internal testes form perfectly fine because the SRY gene worked. The internal ducts form fine. But because testosterone can't be converted to DHT, the external genitalia remains severely undermasculinized. The infant is often born with ambiguous genitalia or female-appearing genitalia and raised as a girl.
But the twist happens at puberty.
It really does. At puberty, the testes start producing such a massive, overwhelming wave of regular testosterone that it manages to override the lack of DHT.
Wait, really?
Yes. The individual, often raised as female, will suddenly experience profound masculinization. Their voice deepens, muscle mass increases, and the phallus enlarges significantly.
That must be quite a shock.
It is. There is a famous cohort in the Dominican Republic with a high rate of this genetic deficiency, historically referred to locally as givedosis, which roughly translates to penis at 12, describing this exact delayed masculinization phenomenon.
That is incredible. But there's another cause of 46XYDSD that involves a completely different mechanism, right? Androgen insensitivity syndrome, or AI.
AIS is one of the most profound biological paradoxes in human medicine.
How so?
In complete AIS, the individual has a 46XY karyotype. The SRY gene works perfectly. The testes form internally. The testes produce normal, even highly elevated levels of testosterone and DHT. The hormones are circulating perfectly in the blood.
But the body simply ignores them.
Exactly. The genetic mutation in AIS affects the androgen receptor. Every cell in the body that is supposed to respond to testosterone has a receptor, a molecular lock that the testosterone key fits into. In AIS, those locks are completely broken or missing.
You know, I think of this like a massive IT failure. The testes are the server, and they are sending a massive critical software update to every computer on the network. But none of the computers have the receiving software installed.
That's a perfect way to visualize it.
The files arrive, but the computers are completely blind to the data. They just sit there, unresponsive.
Because the cells are blind to the masculinizing hormones, the external genitalia develop entirely along the default female pathway. The infant is born with completely female, typical external anatomy and is universally assigned female at birth. The parents have absolutely no reason to suspect anything is different.
But internally, They don't have a uterus or ovaries.
Correct. The testes still produced anti-Müllerian hormone in the womb, which successfully destroyed the precursors for the uterus and fallopian tubes. So they have internal testes, usually hidden in the abdomen or the groin, a short, blind-ending vagina, and no female internal reproductive organs.
What happens when they reach puberty and the testes start churning out even more testosterone? Yeah. If the body still can't read the files, what does it do with all that hormone?
The body never lets a resource go to waste. When that massive surge of testosterone hits the bloodstream and finds no receptors to bind to, an enzyme in the peripheral tissues called aromatase steps in.
And what does aromatase do?
Aromatase chemically grabs that excess testosterone and converts it into estrogen.
Wow. Because the computer can't read the file, it automatically translates it into a completely different language.
The testosterone is chemically translated into estrogen. This estrogen floods the system, leading to breast development and female typical fat distribution. The adolescent develops a female body shape.
So they wouldn't even know.
Often not. They usually only present to a clinician in their mid to late teens when they seek medical advice because they haven't started menstruating, completely unaware that they possess a 46XY karyotype.
The complexity of these hormonal pathways is just staggering. This brings us to the third category, sex chromosome DSDs. This is where the foundation itself, the karyotype, deviates from the standard 46XX or 46XY.
Yes, these variations typically arise from errors during cell division, specifically meiotic non-disjunction, where the chromosomes fail to separate properly into the sperm or the egg. The first major example Dr. Udo cites is Turner syndrome.
Turner syndrome is characterized by a 45X karyotype, right? Right. The individual is entirely missing the second sex chromosome.
That's right. It occurs in approximately 1 in 5,000 female live births. But that prevalence statistic masks a stark biological reality.
What do you mean?
It is estimated that 95 to 99% of all 45X conceptions end in spontaneous miscarriage.
Oh, wow.
It's one of the most common chromosomal abnormalities associated with early pregnancy loss. The fact that a 45X fetus survives to term is, in itself, a testament to biological resilience.
Are there specific maternal factors that increase the risk for that?
Interestingly, no. Dr. Udo explicitly notes that unlike some other chromosomal anomalies like Down syndrome, maternal age is not a predisposing factor for Turner syndrome. It appears to be a completely random error during cell division.
What are the physical manifestations if they do survive to birth?
The missing X chromosome causes profound developmental changes. They typically have a short stature, a distinctively webbed neck, a broad shield-like chest, and a high risk of cardiovascular anomalies, particularly coarctation or narrowing of the aorta.
And what about their reproductive system?
Crucially, their ovaries do not develop properly. They rapidly degenerate into fibrous tissue called streak ovaries. As a result, they do not produce estrogen, will not go through puberty without hormone replacement therapy, and are almost universally infertile.
Got it. On the other side of the chromosome spectrum is Klinefelter syndrome.
Yes. Klinefelter syndrome is a 47,000 XXY karyotype. The individual is genetically male, possessing a Y chromosome and developing tests, but they carry an extra X chromosome. It is actually the most common sex chromosome aneuploidy in humans.
Yet it often goes completely undetected during childhood, doesn't it?
Very often. Because the Y chromosome is present, male external genitalia form, and many patients with Klinefelter are phenotypically normal throughout childhood. The effects of the extra X chromosome usually only become apparent at puberty or later.
What are the clinical clues that might lead to a diagnosis later in life?
They typically grow to a taller stature with disproportionately long limbs. The extra X chromosome interferes with testicular function, leading to smaller, firmer tests that produce less testosterone.
Okay, so a testosterone deficiency.
Yes, which can cause delayed or incomplete puberty, less facial and body hair, and the development of gynecomastia, enlarged breast tissue.
Are there cognitive effects?
They also may experience subtle learning disabilities or deficits in language and executive function, though intelligence is generally within the normal range. Often the diagnosis is only made in adulthood when the individual seeks medical intervention for severe infertility or azoospermia, a lack of sperm in the semen.
Let's discuss Swyer syndrome next. Because this one feels like a fascinating biological outlier.
It really is. Swyer syndrome is a form of complete gonadal dysgenesis. The individual has a standard 46XY karyotype. Genetically, they are male, but their phenotype, their physical appearance at birth, is completely female.
Wait, how's that possible? If the Y chromosome is present, why didn't the testes form?
It all comes back to the project manager. In Swyer syndrome, the Y chromosome is there, but the specific SRY gene is either mutated, deleted, or the downstream genes it relies on are broken. The project manager is literally missing from the construction site.
So the bipotential gonad sits there waiting for instructions, gets nothing, and defaults to the female pathway.
Exactly, because there is no SRY signal, no testes form. Because there are no testes, there are no Sertoli cells to produce anti-Müllerian hormone. Without AMH, the Müllerian ducts freely develop into a normal uterus, fallopian tubes, and upper vagina.
And without Leydig cells, there is no testosterone to masculize the external genitalia.
Right. They are born with female external genitalia and are raised as girls. However, because they don't have a second X chromosome, their gonads don't develop into functioning ovaries. Like in Turner syndrome, they develop non-functional, fibrous streak gonads.
When do they usually find out?
They will typically present as teenagers with delayed puberty and primary amenorrhea because they have no gonads producing sex hormones to trigger breast development or menstruation.
And there is a severe medical risk associated with Swyer syndrome that needs to be managed, correct?
Yes. Those streak gonads containing Y chromosome material carry a very high risk, up to 30% of developing a malignant tumor called a gonadoblastoma. Standard medical protocol dictates the prophylactic surgical removal of these streak gonads as soon as the diagnosis is made to prevent cancer.
Wow, okay. The final condition in this category is ovotesticular DSD. Historically, this is the condition referred to as true hermaphroditism.
Right. In ovotesticular DSD, both true ovarian tissue-containing follicles and true testicular tissue-containing tubules are physically present in the same individual.
How does that physically present?
This can happen in a few ways. They might have one ovary on one side and one testis on the other, or they might have an ovotestis, a single gonad that contains both types of tissue fused together.
What causes a body to build both structures simultaneously?
It often results from a complex genetic phenomenon called chimerism or mosaicism. Different cells within the same individual's body have entirely different genetic makeups.
Wait, different genetics in the same person?
Yes. Some cells might carry a 46XX karyotype, while neighboring cells carry a 46XY karyotype. Depending on how those different cell lines are distributed within the developing bipotential gonad, both types of tissue can be triggered to grow.
So how do they appear physically?
The physical presentation of the external genitalia can range from almost completely male to almost completely female, entirely dependent on how much functional testicular tissue is present and how much testosterone it produces.
You know, when you look across all these categories, from CAH to AIS to Turner and Swyer, you realize the immense responsibility placed on the medical team. They've gathered the clues, navigated the genetics, and finally rendered a diagnosis. Now they have to figure out what to actually do.
Which brings us to the treatment plan, the transition from diagnosis to management. This phase must be strictly compartmentalized into two distinct priorities: the immediate biological emergency and the long-term psychosocial journey.
Let's start with the immediate priority, which is always love preservation. The clinician must assume the newborn is in a state of emergency until proven otherwise. We keep coming back to the adrenal crisis caused by salt-wasting CAH.
Because it is the most lethal immediate threat. If an infant with severe CAH is not treated, they will exhibit progressive weight loss by the second week of life. They will refuse to feed, begin vomiting, and rapidly slip into hypervolemic shock.
Because their vascular space collapses, right?
Yes, their vascular space simply collapses because they cannot hold onto water and sodium. Cardiac arrhythmias follow the potassium spike, and death occurs within days.
If the clinician suspects this is happening, what is the exact protocol?
The protocol is rigid and aggressive. The moment the suspicion arises, you draw the baseline blood labs and you immediately secure intravenous access.
And then what?
You push heavy IV fluids, typically normal saline, to rapidly restore the blood volume and stabilize the blood pressure. You push dextrose to correct the hypoglycemia, and then you administer massive stress dose levels of intravenous hydrocortisone.
To replace the missing cortisol and shut down the runaway brain signals.
Exactly.
But, while the medical team is fighting this biological fire in the ICU, a massive emotional fire is burning in the waiting room. What is happening with the parents?
This is where we hit the absolute golden rule of management regarding sex assignment. The medical team must explicitly, firmly, and compassionately instruct the parents: do not assign a sex immediately, do not name the child, do not send out birth announcements, do not fill out the birth certificate.
I cannot imagine how difficult that conversation is. You are asking terrified, exhausted parents to hit the pause button on the most fundamental social question while their baby is fighting for its life.
It requires immense empathy and masterful communication skills from the clinician. The doctor must provide detailed, comprehensible explanations to the parents. They must gently reassure them that this is a recognized medical condition, that they are not alone, but that the focus must remain entirely on biological stabilization.
They really have to manage the adults in the room to prevent a premature social label that might contradict the biological reality later discovered by the genetic tests.
Precisely. Once the infant is chemically stabilized, the long-term multidisciplinary management phase begins. Dr. Udo's outline makes it clear that no single doctor can handle this alone.
It truly requires a village of highly specialized experts.
It does. You need pediatric endocrinologists to carefully titrate and manage the lifelong hormone replacement therapies. You need geneticists to interpret the karyotypes and counsel the family on future pregnancy risks.
And urologists.
Yes, pediatric urologists and surgeons to assess the internal anatomy. And crucially, you need clinical psychologists and social workers to support the family through the immense emotional weight of the diagnosis.
Let's address the surgical considerations. Historically, the reflex was to immediately operate to normalize the external genitalia. But Dr. Udo notes that surgery comes with significant life-altering complications.
Intervening surgically on the delicate, highly innervated tissues of an infant's genitalia is fraught with risk. The complications can be severe.
Like what?
There is a high risk of post-operative urethral-cutaneous fistulas, an abnormal leaking hole connecting the reconstructed urethra directly to the skin. There is the risk of wound dehiscence, where the surgical incisions fail to heal and pull apart.
That sounds awful.
It is. And there is a significant risk of vaginal stenosis, where surgically constructed vaginal tissue severely narrows and scars, requiring multiple agonizing dilations or further surgeries later in life.
Wow. Because of the high risk of complications and the profound finality of altering a child's body, the process of counseling and the ultimate decision of sex assignment has become a massive ethical dilemma in modern medicine.
Indeed. It is no longer a unilateral decision dictated by the surgeon. Before assigning sex and planning interventions, the multidisciplinary team must consider several pillars.
Such as?
They must deeply understand the pathophysiology and the natural history of the specific condition. Will this child eventually respond to testosterone? Will they naturally feminize at puberty?
Right, like the Dominican Republic cases we talked about.
Exactly. They must coldly evaluate the genuine, realistic possibility of achieving functionally normal, sexually sensate external genitalia through surgery, acknowledging that cosmetically acceptable to a surgeon does not always mean functional for the patient.
They also have to weigh the potential for future fertility, right?
Absolutely. If you have an infant with 46XXXCAH who possesses fully functional ovaries, fallopian tubes, and a uterus, they have a very real potential for future pregnancy and childbearing if they are raised female and their hormones are managed.
Right.
To ignore that potential would be a profound medical failure.
And moving beyond the raw biology, the medical team has to navigate the cultural, religious, and psychological context of the specific family they are treating.
The overarching mandate is shared decision-making. The medical team provides all the data, the risks, and the long-term outlooks, but they must obtain fully informed, deeply considered consent from the parents.
Let's step back and look at the whole picture, because what we have explored today completely shatters the grade school biology concept of human sexual differentiation.
It really does.
It isn't a simple coin flip. It is a wildly complex, multi-step biological cascade involving genetic project managers, enzymatic assembly lines, and cellular receptors. And when that cascade takes an unexpected turn, the medical response requires prioritizing immediate survival over our deep societal urge to categorize people neatly.
It is a powerful reminder that human biology rarely adheres to the strict, socially constructed boxes we try to force it into. The biological reality is fluid, responsive, and infinitely complex.
Which leaves us with a final thought to chew on. Think back to that landmark consensus in 2006.
Right, the terminology change?
The global medical community looked at its own history and realized it had to officially change its terminology. They retired words like hermaphrodite because they recognized that the language was confusing, pejorative, and ultimately failing their patients.
Yes.
The medical vocabulary had to evolve to catch up with basic human empathy and scientific reality.
It forces a compelling perspective on our current moment, doesn't it? You have to wonder how our present-day clinical practices will be viewed 20 or 30 years from now.
Exactly. As our understanding of the genome deepens, And as the medical community listens more intently to the lived experiences of adult patients who grew up with DSDs, how will future generations view our current reliance on early surgical interventions and immediate gender assignment?
That's the big question.
Does our medical practice dictate our culture, or does our culture dictate our medical practice? The next time you see an X-ray, or you think of a diagnosis as a simple, jagged white line, remember the complex, resilient reality of human biology. There's always more beneath the surface.
Beautifully said.
Thanks for joining us on this deep dive.